let's take a look now about some of our goals. I mean,
Right.
there are people whose cholesterols are too high. We can define what too high is, and we should, by the way. What is your goal in lipid lowering to decrease cardiovascular risk?
So the minimum I want it to reduce is 30 to 40%. And the reason for that is vascular biology. You want to make the endothelium, the inner lining of the blood vessel, behave in a manner that's not permissive for the formation of atherosclerosis. And you'd like the plaque to start changing. If you go less than that, you're not going to get it. After that, you go for numeric targets. Numeric targets, we see that if you get below 70, you're going to do better.
That's 70 for your LDL.
Exactly correct.
Okay.
Right. Now, sometimes if your LDL is 250, you have a long way to go. It's not going to be so easy to do even without one of the newer drugs that's available. But under 200 and a little bit of cooperation from the patient, you may be able to get to a goal of 70.
Because I want to start out where you started out, which is the percentage reduction. All right. To me, a percentage reduction is suboptimal in this regard. You start out with 300, you're going to take it down by 30%. You're down to 200. That's not so good. So why don't you just start with the numerical number from the beginning?
Well, the reason I don't do these, because a lot of people come into the office, 20s and 30s, being told by their physician they need a statin. They're against starting a statin early, and after a dialogue that more or less says, no, this is not poison, when this is not the dark side, you'll do okay, they still want to try to do something on their own. So I find that you encourage people to try to do things on their own, to diet, try lifestyle. If you give them a finite amount of time in which you say, look, let's do this again in 3 months. After that, well, let's make a deal is over. And if you haven't got where you have to go, we're going to do something. And that the number you got to tell them is you got to get this down either below an LDL of below 130 for sure, preferably below 100, or you got to get a minimum of 40%. And for that reason, because if they get anything from their lifestyle, maybe it means one medicine rather than two.
All right.
But Howard's really referring to primary prevention.
Right.
Right? And he and I would say, probably practice almost exactly the same, which is if you had somebody with secondary prevention,
Different story.
It's a totally different story. Somebody who's had an infarct, somebody who has familial hypercholesterolemia, somebody who's a much higher risk patient, you want to get that LDL down as low as possible.
I'll start with the obvious pulling the pin on the grenade and say, you'll forgive me, but secondary prevention, isn't that again closing the barn door after the horse is gone? Wouldn't you rather say, I'm not going to wait for your MI, I'm going to give you a statin?
Of course, but we don't have that opportunity.
You're going to pay for that?
Absolutely.
You will?
My role as a family physician, I practice primary prevention. I start seeing patients essentially when they're born and try to do the best at preventive medicine that I can. And it's paid for.
Yeah, but look, I can remember the day when the statins were first introduced, and they were expensive.
Sure.
You know, if you had an LDL of 130, you didn't get it unless you were high risk or class 2 prevention. You guys and you women told the clinicians, no atorvastatin for your patients because they don't meet the high risk category. That's changed, right? So were you wrong? Were you wrong back then?
We were wrong back then, yes. So the question is, you know, for example, when you have a conversation with your patient who's in their 20s or 30s, starting dietary interventions first, how successful are we?
I'm very successful, but that's because I talk to people. Most physicians don't have the luxury of an office visit that's 20 to 30 minutes.
Right.
Most guys have seen 2 or 3 people in that time, and you don't get much of a chance.
Give me a definition when you say I'm very successful with diet and exercise.
75%.
75% what?
Of people who change their diet, lose weight, and drop their cholesterol meaningfully and perpetually.
All right, so you see a meaningful decrease in LDL cholesterol with diet and exercise, lifestyle changes.
In a particular patient population.
In the primary prevention population.
Primary prevention with an LDL elevation that's not based on FH. Okay, so that's a different, again, that's a different.
That's not going to work.
We're not talking.
We're not talking. I just want to clarify that. So we're just not. And I would say the same. I get the same result.
You all were talking about the diet books earlier. The reason there's so many diet books is they don't work, right? And everybody thinks the next diet book is the diet book. So what's different about your patients that it works when the vast majority of Americans can't even lose 5 pounds?
Because they come into me already motivated to try it. They come in, try to not be on a medicine, and they come in wanting to do something. So immediately I harness that. And the diet that I use is the only one with data. It's the Mediterranean diet.
Okay.
Mediterranean diet has data on events, and it's followable, and it's palatable. It's not, you don't have to eat birdseed and cardboard and never drink alcohol. And I think it's something that people can go after.
All right, it does work.
Yeah.
All right, so you don't need the cabbage diet.
Right.
You don't need the pineapple diet.
Right.
The eat only peas on Tuesdays diet.
No, the
All of
Tuesdays
which
are
work
tough.
if you stick to them, but nobody can stick to them.
I agree with you 100%.
So, yeah, go ahead.
I was just going to ask if 75% success rate is your norm, why is it that we said 80% of the population is not really where
'Cause
they
they're not
should
seeing
be?
him.
It's a selective population.
It's a very
Right.
selective.
Right. There
So
are people
past
who
performance is no indication of
and
future profits.
Other ones come in and say, let me get this straight. I can't go to McDonald's and Taco Bell and visit the Colonel. I want no part of this. And they say, give me the medicine. And they use the medicines to eat like a pig. And so we get great looking numbers with expanding waistlines.
By the time you get those patients that you're recommending lifestyle changes to, a fair number of the other patients have dropped off.
Right.
The folks who can't do it, won't do it. Is it a majority that drop off or a minority?
About 2/3.
A majority. That's a lot. So for you to sit there and tell these guys, I'm going to do this with diet and exercise, 66% not going to get it done. Is that what you heard?
That's what I heard.
Is that what you heard?
That's what I heard.
Yeah, but the point of the matter is, of the people, okay, you can still make a difference with prevention if in people who are going to need drugs by doing diet and exercise, so that you don't have them entering the medicine with an LDL of 190. They're entering with 130.
Okay.
They need less medicine. Their goals are more attainable. And patients, you should know, you guys know, you start giving a patient more than one drug, they immediately start freaking out. What's the adherence to statins? After 6 months, how many people don't refill? A lot.